Hello everyone, welcome back to Instagram Live with Intimate Rose. It's our reoccurring show with myself, Dr. Amanda, and Andrea Martin of Andrea's Explains It All. And today our topic is joint and musculoskeletal pain in perimenopause and menopause. So Andrea and I are going to be discussing all of the different ways that fluctuating hormones can result in this really interesting symptom that is often overlooked. It certainly could be driven by other things. Joint and musculoskeletal pain in that phase of life is certainly very common as a byproduct of being a person and using your body. So it's always a really good idea to get screened, see a physical therapist for joint pain, but we're going to talk about why some of these things pop up and the role that estrogen plays and fluctuating relationships between estrogen and its neighbors, progesterone and testosterone, affect your joints and your muscles. So if you have any questions as we're going, please don't hesitate to ask them. And Andrea should be on any minute now. In the meanwhile, we have lots of sales going on at Intimate Rose, so be sure to visit our website and check those out. But we're running specials on all kinds of different pain and pelvic health tools, so if you have on your list of New Year's resolutions to take better care of yourself, be sure to check those out. Hi, Andrea.
Hi.
It's the Andy to my Mandy.
Yay.
So good to see
Yay, internet, it worked and connected us.
Very good. So, Andrea, today our topic is joint and musculoskeletal pain during perimenopause and menopause. And certainly as a physical therapist, I've got a lot to say about that. But you're going to kick it off and talk about hormones and how they fluctuate and how that can bring about this really interesting symptom that's often overlooked in that period.
Oh, yes. I have much to say, so feel free to cut me off at any point.
Never.
So, no, please do. I'm actually going to go more in depth. There's a recent-ish kind of study that came out that was really good. Dr. Von der Wright did it on call it the musculoskeletal syndrome of menopause. So basically, we found that about like 71% of women will experience these changes in their musculoskeletal system after menopause. About a quarter have like really severe symptoms. But what I think is most interesting is that 40% have no structural findings, meaning if you go to your doctor, nurse practitioner, whatever, and say, I'm having this pain, I'm having, that, they do imaging, looks fine, looks totally normal, which of course is hugely frustrating. And there's big changes that happen in this whole system, very important system of our body, because of declines in estradiol. So estradiol is like the most biologically active form of estrogen. And it affects all types of tissues in your whole body, but especially the musculoskeletal system, your muscles, your bones, your tendons, cartilage, ligaments, all the things. And this is, it's kind of funny. It's 2024. This study just came out, and a lot of this, we're just learning a lot of this. We need to learn more. You look at some of this stuff and it's like, how are we just figuring this out now? But here we are. But there's 5 kind of big changes that you see within the musculoskeletal system relating to declining levels of estrogen, which is what happens when we reach menopause. At first you come into perimenopause and it's a lot of up and down and up and down. And at first, sometimes even estrogen levels are higher, but then over time they start to get a little less and less, and then it just kind of steady decline. So these 5 big changes that happen, and I'll go into each one. We see more inflammation, sarcopenia, and I'll explain what that is, decreased satellite cell proliferation, osteoporosis, and arthritis. So we'll start with the inflammation portion of things. So inflammation you might see as like joint pain, frozen shoulder is a big one in postmenopausal women when, you get like this capsule around your shoulder that just kind of contracts, and it's painful, and you have like less range of motion. And we know, just like in the cardiovascular system, that estradiol is anti-inflammatory in your musculoskeletal system. So it inhibits breakdown of muscle proteins, it helps with muscle repair. And when, estrogen drops, now you've got this increased level of inflammation that we could see in the musculoskeletal system. So sarcopenia is the next one, and that's kind of like your loss of muscle mass and function over time. We lose about, it's 0.6% of our muscle mass every year after menopause. So estrogen helps keep the cells healthy in tons of ways. It helps them to use energy, it helps maintain levels of antioxidants. And the type of things you'll see in someone with sarcopenia is like falling more, poor balance, less stamina, walking slowly. I hate this when you're like walking up to a door and there's someone behind you and you hold the door, but they're walking real slowly and you're like, do I just close it because now I'm pressuring them to walk faster and they can't? Or do I hold it because it's rude? But we can see those huge changes in just your function from loss of muscle mass. And it was interesting. There's one study that showed that postmenopausal women, when they did like estrogen supplementation, they actually had stronger grip strength. So the next topic on our list are these satellite cell proliferation. So I like satellite cells. I think of them as like little ambulances that like woo, woo, rush into the scene. So they're like stem cells on muscle fibers, and they help with regeneration and muscle repair. And of course, estradiol stimulates activation of these cells. So again, your estrogen levels decrease, and your little ambulances aren't quite there as much to help with, recovery. And think of how, I'm sure you know very well, even when you're just exercising, say you're lifting weights, it's like a lot of little like micro injury to the muscles, which is like a good thing because then you can over time build more muscle mass. If you don't have your little ambulance guys coming in to help repair, it really prohibits, like a lot of women after menopause are like, I'm having trouble. I feel like I'm doing the same stuff I used to do, and I'm not necessarily gaining muscle mass, or again, losing muscle mass. Then we've got osteoporosis. So this is a huge one. It's a sticky point for me because osteoporosis, which is like a decrease in bone density, and your bones become more brittle. They become like almost like Swiss cheese like. It is so underdiagnosed, but so preventable. So just to give you a little foray into the medical world, DEXA scans, which are bone scans to look at your bone mineral density. Most insurance won't approve a DEXA scan for the average bear until age 65. Well, we lose 10% of our bone muscle mass in peri-menopause. The majority of it you start losing 2 years before menopause. So if the average age of menopause is 51, why the heck are we waiting 15 years to then go back and decide to check and see what's going on here? Are we losing any bone mass? Because it's so preventable. And it's really devastating. 70% of hip fractures happen to women, and a quarter of women who fracture a hip will end up requiring long-term care after a fracture. And it's absolutely devastating. Like, I always think about my grandmother, like she's like this little old Italian lady. She lived in the Bronx. She was always cooking and this and that. And she went out to buy ravioli, which always surprised me because she always made her own ravioli. But maybe she was tired that day. She went out to get her ravioli, and her hip broke, and she never saw the outside of a hospital again. She passed away within about a month, and you hear these stories all the time. And knowing that if, maybe somebody would have done something about it earlier, it's very frustrating. And I'm sure you have family members or know people, like we hear these things all the time. In the United States, hormone replacement therapy, or estrogen, is only approved for the treatment of osteopenia, which is kind of like osteopenia is this arbitrary number we came up with, like when your bone mass gets to here, it's like pre-osteoporosis. And then, once it gets worse, now you're in osteoporosis range. So it's, again, it's approved for treatment of osteopenia, prevention of osteoporosis, and works really, really well. Um, it's interesting too. It's that estrogen has been shown to decrease fracture risk even in people that don't have osteoporosis. So I'm very curious. I want to look into that more and see why that happens. But again, my kind of bone to pick with bone.
I see what you did there.
I didn't even mean to. I couldn't let that go. But my issue with this whole osteopenia versus osteoporosis thing. So in Australia, we're allowed, it's proved you can treat osteoporosis with estrogen therapy. And we have some data that not only does estrogen prevent bone loss, that it might build it back. But here's the thing, when going back to those DEXA scans, when you look at a DEXA scan, it breaks things down by bone. So it typically looks at like both your femurs, both your hips, and your spine. So why wouldn't we, if say you've just got osteoporosis in your spine, but not yet in like your femurs or your hips, why wouldn't we then use the estrogen to prevent the other areas from progressing to osteoporosis? I don't know, just a thought. But I guess I'm a crazy person for having these thoughts. And then number 5, our last big change that we see is arthritis. So osteoarthritis is when, the cartilage in your joints kind of breaks down over time. Wear and tear, just like my appliances in my house have wear and tear. I would expect by the time I get to, 50s, 60s, whatever, some things aren't going to quite work as well as they used to. But interestingly, in women, diagnosis of osteoarthritis increases dramatically once you hit menopausal age. And women usually have more debilitating pain than men do. And some of this we know is because estrogen plays a role in regulating chondrocytes. So they're little cells that kind of help with, they help with the part that makes your joints and stuff, like the tissue of it, springy and shock absorbing. So again, when we lose that, what happens to our joints? This area is a little controversial. If should we use estrogen replacement therapy for osteoarthritis? There's some data that it's protective for the discs in your spine, but then there was one study that showed that people that were on hormone therapy had more incidence of joint replacement. So I don't know there. Again, one study, we need way more information. But again, these are all these big changes that happen in our musculoskeletal system that don't typically get a whole lot of airtime, or, we're not always aware of these things. So.
It's so true. My first exposure to this, and I was talking with a few physicians on this topic a few weeks ago, but it was in physical therapy school when we were learning orthopedics and talking about frozen shoulder, and about how the incidence rates of frozen shoulder was significantly higher. I don't remember this, that would be 17 years ago, so that data would be old anyways. But the incidence rate of frozen shoulder, wherein a person loses range of motion in their shoulder, they aren't able to elevate often very high, which means they can't reach up to their shelves functionally. They can't necessarily reach back behind them to get something that they need. It's very functionally difficult for them and can be very painful. And the incidence rate for one was significantly higher. And the discussion was, why is that? And we were told it was due to declining levels of estrogen. And it was like, you've got to be kidding me. What? Who made this? This thing is defective. But seeing that clinically, it is so interesting how fibrotic the shoulder joint can become. And certainly we can push through, but it's a very challenging process that takes a long time. And then certainly the changes, as you mentioned, to bone mass. And that's why we always encourage women to be participating in impact activities, whether it's step aerobics or Zumba, and then also lifting
Yes.
heavy things in order to maintain muscle mass. As you mentioned, grip strength, I mean, thinking about independence, thinking about your ability to open the pickle jar. You know, a lot of women are living alone in that period of their life for
Mm-hmm.
many different reasons, but being able to access your food and to get up in the middle of the night to go to the bathroom, you know, urinary incontinence is often associated with declining levels of estrogen
Mm-hmm.
as well. And after the age of 65, we call it normal to get up at least once per night. We call it once per night. North of that would be a bit excessive, and we would be addressing that in pelvic health physical therapy and with hormone therapy as well. But the fall rates of getting up in the middle of the night are very high. And then, as you mentioned, if they fall and they are osteoporotic,
Mm-hmm.
they fracture, they do go into often care and assisted living, and mortality rates are usually within 2 years after hip fracture. So it causes this
Yep.
whole train wreck of different changes to their life and sometimes the end of their life. So from a physical therapy standpoint, we're encouraging weight bearing activity, we're encouraging heavy lifting, and then we are encouraging seeking solutions through hormone therapy as well to help maintain all of these things. And regarding the late onset of those DEXA scans, it was really funny. Ellen DeGeneres has a new stand up comedy special. It's very good. And she said that her physician, she went in for her yearly physical and
Mm-hmm.
she's in her mid 60s. And they said, "Oh, you are overdue. You need to go." And she said, "I'm fine. I dance on stage for a living." You know, she was in full blown osteoporosis.
Wow.
And that's really hard to reverse at that point. So changes, asking for it because it's not being recommended often. Oh no. I think Instagram is sneezing. Hopefully you all can still see me. It's not often recommended as part of this ongoing monitoring of care. So you have to advocate for yourself.
Yes. And there are ways to get around it and ways to get insurance coverage. So if I've got someone who's got like a mom with osteoporosis or, you know, that type of thing, I can get it covered. Or like I have a patient who is on chronic steroid use, and that puts her at higher risk. And she's not 65 yet, and I believe it should be covered. Um, Worst comes to worst, there are places that like you can pay out of pocket and pay cash, which, you know, not ideal, but there are ways, you know, to get it done. But I just can't advocate enough for getting these done early. The, the guidelines are, and insurance isn't going to change until the guidelines change. And the guidelines are stupid. They're just incredibly unhelpful. But you know, someday if we keep whining about it enough, I hope that it will change. Um, but I like how you said about like lifting heavy weights. I know a lot of women like to do these little like dinky weights, and I hear all the time like, I don't want to get bulky. I'm like, you are not gonna get bulky. You would have to try so hard and put like so much effort and devote your whole life to getting like bulky. It's not going to happen. So you will be fine. Maybe you'll get some little like muscle definition, which who doesn't love that? But trust me, you're not going to wake up and, you know, you're Arnold Schwarzenegger all of a sudden.
If only.
I know. If it was that easy, there'd be a lot more people with giant muscles walking around. Um, and you mentioned like the like urinary incontinence, you know, people forget pelvic floor, whole bunch of muscles in there. And that absolutely, you know, decreasing levels of estrogen, progesterone can influence, you know, the tone of the muscles. You know, there's less elasticity. You know, you can get more, like you said, people with like urinary incontinence or pelvic organ prolapse, all types of things, all types of things. So, the pelvic floor, I feel like it's a bunch of muscles, but like the forgotten muscle of the body that we just kind of skip over in life.
But it is muscle just like everywhere else,
Yes.
and it can be weak, it can be too tight, it can be
Mm-hmm.
flexible, it can be stiff, and we need it to be both strong and mobile for
Yes.
continence and for ease of bowel movements and intercourse and all of those interesting things. But it is also at the whim of sarcopenia, because of that systematic effect on the musculoskeletal system and overall decline in those muscle cells that are different from other cells in the body. They do require to be used. They
Yes.
do require exercise,
Mm-hmm.
which can be done with a lot of really common hip exercises like bridges and clamshells and squats and those kinds of things, because the pelvic floor does share a fascial plane with the gluteal muscles and the hip rotators. But if you are experiencing those symptoms, oftentimes they require a little bit more attention and a little bit more focus on really activating the muscles themselves. So we want them strong and mobile, all of the things, just like we want your hamstrings and your quads and your shoulder to
Yes.
be mobile.
Yes. I find a lot of women are like, I would say, like out of touch with our pelvic floor. Like, we don't know who she is, where she is, what she does, what it feels like, if it's clenched or relaxed. In the office, I'll try to help people like engage a bit, right? I'll try and teach them how to squeeze their pelvic floor, and it's like nothing.
Yeah.
Or it's the opposite, where it's like squeeze, and I'm like, you can let go now. You can let go now. And they're like, I am. So, and then, I send them off to my very favorite pelvic floor physical therapist. Say, I tap out, you're better at this. Teach them how to do this stuff, please.
That's right.
But yeah, so it's I always say it's just this forgotten area. We can't see it.
Yeah.
Like other health specialties don't really talk about it. It's a lot of like, oh, I treat from here to here, and then I treat from like there to there, and then like, who treats the pelvic floor? So like you said, just get in touch with her.
That's exactly right.
Activate
And then
her.
you call up your favorite pelvic physical and occupational therapists who are
Yes.
happy to help and look at the whole person, and we work together as a team. I always call it like a rowboat. We're all in the rowboat together, and we're all paddling to get that person towards their goals. And we all have an oar, and it's a special oar that does something unique.
I love that. I love that. Yeah, it takes a village.
That's We had a question. I'm going to scroll up here. What about those pelvic floor muscles affecting the nerves for your legs and walking? Yes. So the nerves that go to the pelvic floor and the legs come out of the sacrum. So it's that kind of a brick of a bone at the very base of your spine. The nerves go into the pelvic floor muscles. That is how, when we sneeze or cough, the muscles contract, because they have nice nerves that tell them to do so. And then likewise, when to relax. All of that coordination takes place between the brain and the spinal cord and the nerves going into the muscles themselves. It's this nice little chorus. Additionally, the nerves to your legs come out of the lumbar spine, and some of them come out of the sacral spine as well. So if you do have pelvic floor muscles that are too tight, a couple of things can happen. It can compress on the nerves, which can send a referral of pain, which is kind of like, it's when we have this kind of block of pain that encompasses multiple areas. It's really common to have it in the front of your thigh, in the hip, in your abdomen, in your back, and sometimes going down your legs. Going back down your legs can also be associated with the nerves coming out of the lower back spine as well. But what can happen is, over time, if that happens a lot, those nerves can become very excited, and they can start to be irritated by inflammation in the area, and also by contracting of multiple muscle groups. One of the analogies that I like is, if somebody broke into your neighbor's home, they would get a new security system, they would get a new dog, and they would lock it down. And so would you. You would be very alerted if your neighbor's house got broken into. So that speaks to the fact that if we have clamping down and guarding in the pelvic floor muscles, sometimes the quad muscles in the abdomen say, us too, we're all going to guard you, and we're going to protect you, and we're going to clench, which can drive some of these nervy type symptoms. So that was a really long-winded way of saying, yes, they are related. There are different sections of the nerves, but oftentimes they can be irritated together. And that's why it's really important to have somebody look at your whole body. So when you come in for a pelvic health evaluation, we're going to look at you standing. We're going to ask you to squat down and stand up. We're going to ask you to bend over and touch your toes, lean back. We're looking at how your spine and your hips move because they are really integral to what is happening throughout and with the pelvic floor as well. So we're not just looking at your pelvic floor, we're looking at all of you as a person.
I love your explanation. I'd like to empty your brain inside of my brain.
I would
so I can
like to empty your brain inside of mine. I feel like my life would be more enjoyable.
I don't know, to be determined. And of course, as soon as you start talking about the dog, I'm like, I wonder what kind of dog they got.
Well, they would get a Labradoodle, they would name her Rosie, and we would call her a Labiadoodle.
Yes, because that's what we would do. I know. I have my guard Maltipoo next to me, who may not be the best deterrent.
Well, if she's loud, you could get her one of those voice modifiers.
I know. So she sounds like a pit bull or something.
That's right.
She is loud, but we have a little bit of hearing loss, a little bit of dementia, so sometimes we face the wrong way when we bark.
Oh, baby.
I
We're
know.
gonna do that too when we're older.
I know.
I'm gonna yell at you because you are not getting appropriate hormone therapy, but it might be over there.
Speaking of dogs, I actually have a friend who, kind of off topic, but not really, had a dog with urinary incontinence after she was spayed. So they removed their uterus and their ovaries and the tubes. They had to give her estrogen to help, like vaginal estrogen, to help with their urinary incontinence, and it took it away.
So here's a funny secret that I don't often broadcast. In pelvic health physical therapy, when somebody has surgery, laparoscopic, C-section, appendectomy, or otherwise, we do soft tissue mobilization and visceral mobilization of the scar tissue and of the abdomen. I had the world's most amazing black lab, and after we had her spayed, she had new onset at age 2 of urinary incontinence, and I was, being the pelvic health therapist that I am, I was like, let's see if this is a pressure issue. Get her on her back, and get my little fingers in over her scar, start mobilizing it, do that multiple nights per week for a few weeks. Gone. Girlfriend was continent.
That's amazing.
And I have since gone on to do it for other friends.
I love that. First of all, what a lucky dog. She landed in the right household, and probably every night was like, oh, thanks, Mom. I get belly rubs. But that's so cool.
Yeah, it's a special skill. So if you have a dog with a new onset of incontinence, obviously check for UTI, but also call your pelvic physical therapy friend and get some special tummy rubs.
That's the job I want.
Tummy rub of the dogs.
Yes.
I'll teach you.
Okay, I would love to. That just made my day.
I don't think I've ever told people that broadly, but yeah,
You should.
I treat dog incontinence.
You should tell all the people that. Really should though. I'm just gonna shut up. I can talk about that for hours. I'm so excited about that.
No.
The people just tuning in are like, I thought this was about menopause and muscles and bones. Why are they talking about dogs?
We digress. That's what makes us who we are. Annie and Mandy.
That is us.
Thank you so much for joining me today. I appreciate your expertise and your time. We will be together again in 2 weeks, which will be January 2nd. It will be in the new year. We have a topic. I don't remember it at this time, but we have
I
a
don't either. I was about to be like, no, 2 weeks is the week of Christmas. No, that's next week.
I know. It's here. It came in like a freight train.
It's a coming. We're
Right.
ready for it.
That's right. We're ready. I got my stockings hung
I know.
by the banister
Oh, it's so cute
with
back
care.
there. You did a good job.
Thank you. All right, my dear. It's so good to see you. I can't wait to
You
see you
too.
again. Have
I
a good rest
know.
of your day.
You too.
Bye.